with some small muscles down here that we're not going to dissect. There's a lot of, in terms of the facets here, they allow for a lot of rotational and anterior posterior bending. So a lot of movement there. If you look on a plain film X-ray here, you can see the different pieces and parts really well in the lumbar region. You can see that on this lateral view, the bodies, the pedicles, the spinous processes are sticking off here. You can see the transverse processes protruding out laterally here. You can see the disc spaces and very, very prominent. The intervertebral foramina you can see here quite nicely. The thing about the vertebral bodies is in a young person, they're nice rectangles like that with clear edges. As you get older, they start looking more like this with these cutouts here, degeneration right here, and these lips, if you will, protuberances that stick up anteriorly. These things cause a lot of problems as you get older with generalized back pain. Osteophytes is what you call those protuberances. The sacrum has started out as 5 separate vertebrae that fused. When they fused, they actually fused so that there were 8 holes on the ventral surface and 8 other holes on the dorsal surface. So what happens there is where the intervertebral foramen is up in the lumbar region, you got the dorsal and ventral root, they come together. There's the dorsal root ganglion. They go through the intervertebral foramen and then divide into dorsal and primary ramen. Well, down in the sacrum, what happens is that they stay separate. We'll go with that. They stay separate. So the cauda equina will have the dorsal rootlets and the ventral rootlets, and they go out separate holes. Okay, you still find the dorsal root ganglion associated with the dorsal sacral foramina, but they don't come together like spinal nerves like you see up in front. Okay? The coccyx down here is, they have it illustrated as 4. It looks like they're all fused, and that's a picture that you see a lot. Sometimes the coccyx can be pointed forward like this in the tailbone. So as part of the obstetric exam, you want to make sure that there's enough distance between, if you put your finger in the vagina, there's the pubic bone, and the coccyx here, that's the narrowest diameter in the pelvis. So you need to make sure that the baby's head and shoulders can get through that diameter if you're going to have a vaginal birth. A friend of mine, when she delivered, her coccyx broke and it straightened out. And for quite a few months after her delivery, she couldn't sit down because of her fractured coccyx. And you don't fix a fractured coccyx. So, okay. The sacrum has a large articular surface with the ilium bones of the hip. We'll get into later. There's an opening down here called the sacral hiatus. Remember the filum terminale that came off the end of the spinal cord? It travels down through the sacral canal, comes out the sacral hiatus, and attaches to the coccyx down here. So that's where the filum terminale attaches. So you have ventral foramina, dorsal foramina. One transmits the ventral primary ramen, the dorsal is the dorsal primary. I mentioned this yesterday, in this earlier today, the primary and secondary curvatures. In fact, the spinal cord of the baby goes way down almost to the end. Was that your husband or your boyfriend?
My husband, yeah.
And here as you age. When things go wrong, this is kind of what it looks like. First of all, this is it's called a dowager's hump, or thoracic kyphosis. You see this a lot in the little old ladies with osteoporosis, degenerative disease of the spine, where they're all hunched over like this. Occurs in men too, but probably 99 to 1 women to men. If you get an X-ray, it's just amazing how much arch you'll see in that thoracic spine. So that's kyphosis, thoracic kyphosis. This right here is an exaggerated lumbar lordosis. This is called layperson swayback, because the swayback horse here. Anyway, this can or doesn't have to be pathologic. If you watch the Olympics and those little gymnasts, they can sit there and do like that, and it's almost grotesque how much lordosis they have in their L-spine. This is scoliosis here, the curvature of the spine. You see that, it looks like a snake. If it's severe enough, there is a procedure where they go in and open you up completely in the back and put hardware in there to straighten you up. A friend of my daughter's, a school friend of hers, had this done a couple of years ago when she was about in the probably 6th or 7th grade, and it was a horrendous surgery, obviously, and quite painful. But the good news is when she came out of surgery, she was 2 inches taller. So the way that you would, what happened to our person here? Oh, she ran away? We're in here next up. Come on over here. Let me take your scarf off. So during the physical exam, you would test the motor function of the legs, but one of the things is you want to test the spine, right? Range of motion of the spine, and you want to test for scoliosis. So what you want to do is just place your hands on their hips. Can you bend over slowly and touch your toes? And as she's bending over, you're looking at her, you're running your fingers down her spine here to make sure that it's straight. Now, slowly come up. There you go. All right, so it's going to stand up. So here's the little trick that I learned. Wait, hang on. So if I say, bend over, touch toes, all right? Come up slowly. If you say come up slowly, they get like 90% of the way up and then they slow down. But if you say slowly come up, they come up slowly all the way. So there's a little thing, you need a little trick. All right, so the next thing I do is I want you to lean back. I'm going to stabilize your hips, lean back as far as you can. All right, so I'm testing extension of the lumbar spine. Straighten up. Now take this hand and run it down that leg. So lateral bending the other way. Okay. Now just turn around and look at the wall. I'm holding it. You're trying to stabilize the lower extremity. Turn around and look at the wall. Turn around the other way and look at the wall. Okay, there you go. So there you go. Okay. It's kind of weird when you do physicals on these dancers here on campus. I mean, they're like, you can take them and just bend them all the way around. Here's a couple of other disorders here. This one over here is a compression fracture of the body of the vertebra. This happens a lot in those little old ladies with osteoporosis. Doesn't happen very often in healthy bones at all, unless there's a significant fall from a height or a car wreck or something like that. By the way, a car wreck is called an MVC, motor vehicle collision, MVC. Two things you learned today, MCV and CVA, right? Okay. Over here is a disorder called spondylolisthesis. It's essentially a movement of the lumbar vertebra on each other. It's a disorder that usually you'll see it in young people, 20-something years old, chronic back pain. You get an X-ray and you see that these things don't line up. You know, they don't line. You don't have neurological deficits so much as you have just chronic back pain. And the way you, one of the ways you can diagnose this, in addition to that, is if you x-ray them at an oblique angle. If you squint your eyes right here, you kind of have to imagine this a little bit. If you look at that right there, there's a Scotty dog. Like a Scottish terrier. See that? There's his eye, there's his ears sticking up, there's another one up here. There's his front leg, there's his body, there's his tail. See that?
Oh, yeah.
So in spondylolisthesis, you'll have a Scotty dog with a broken neck.
Oh.
So that's a... if you saw something like that, you'd immediately get an MRI or start with a CT to investigate that. This is a disorder where during development, the closure of the what's called the posterior neuropore, which is when you start developing your nervous system, you sort of start in the middle, and you develop the spinal cord and the vertebrae and everything, and everything closes up, starting in the middle and towards the front and the back. If it stays open in the top, that's called anencephaly. You have this opening up here, no brain. It's an immediate death after birth. If the posterior neuropore fails to close completely, you can develop 3 levels here. Meningomyelocele is where the meninges, the myelo is the spinal cord, or the called equina actually, protrude out an opening in the back right there. The lamina did not fuse, so it's open. These folks are always paraplegic. There's no cure for it. They'll always be paraplegic. They always have cerebrospinal fluid drainage problems. So they always wind up with a shunt in the brain to drain off cerebrospinal fluid into the chest cavity or abdomen, always. It just happens. So next, in the least severe, is a meningocele. That's just where the meninges protrude out the defect, the bony defect, and the nervous tissue, the cauda equina, may or may not be affected. May or may not be affected. It's still open back here. It's still like that, but most of the time it's going to produce paraplegia as well. This one right here is called spina bifida occulta, where you have a defect in the bony lamina. You see right here, the defect in the bony lamina. However, the defect in the bony lamina, however, the nervous system is intact. These people do not have neurologic problems. If you get an x-ray on them here, there's the defect. This would be the lamina here, and there's a defect in the lamina. You see the lamina up here on this one. There's the lamina, there's the spinous process. There's a defect right there. So this person may not even know they have spina bifida, and that's why it's called occulta. It's hidden. Interestingly, because hair and nervous tissue and skin are all derived from the same embryonic tissue type, they wind up with these hair patches on their back right here in their lumbar region. If you see somebody with an unusual looking tuft of hair in the low lumbar region, I'm not kidding with you, that's one of the things you should think about is spina bifida occulta. I've seen it so many times, it's just not uncommon. Okay? Ligaments of the vertebral column. We've talked about this one right here. Remember this one right here? We've cut away the lamina to expose the posterior longitudinal ligament. If you look anteriorly, look how wide the anterior longitudinal ligament is. So if you're going to have a herniated disc, where is it going to herniate? It's going to herniate in a posterior lateral direction. That's the most common type of herniation of the disc, and unfortunately that's where your intervertebral foramina are, and that's where the radiculopathy comes in. if
Dr.
you,
Tim,
yeah,
what is radiculopathy?
it's R-A-D-I-C, opathy. Radiculopathy means associated with a nerve, like a ventral primary ramus. Like the ulnar nerve goes to this part of my hand. So if I have paresthesias down here, that is a radiculopathy. If I have weakness in my ulnar nerve distribution, then that is a radiculopathy. Okay, that's basically it. Don't wait so long to ask questions like that. Okay, so if you don't understand something, stop me. I mean, don't ask like black holes or plasma physics or anything like that. So another ligament I want you to know here is, one you should know, is this one right here. It's called ligamentum flavum or ligamentum flavum. Now, what we've done is that ligament essentially goes from lamina to lamina. So if we take away the body, you see, in this one right here, we took away the lamina, so we're looking at the back of the vertebral bodies. Here, we've taken away the bodies, and we're looking at the undersurface of the lamina. Right? You follow that?
Yeah.
So the ligamentum flavum goes from lamina to lamina. And the reason that's important is, remember we were talking about our spinal tap we did on you yesterday, and we felt that defect. That's where we're going to put the needle. When you insert the needle, it's going to go between the lamina. It's got to go between the lamina. You can't push it through the lamina. And when you push it through ligamentum flavum, it pops. You can feel it and hear it pop. That's when you know you're in initially the epidural space. A little bit more, and you're going to be in the lumbar system. So that's a very important ligament in terms of doing an LP. Let's see, I think that's really... I mentioned this yesterday in a cross-section. I want to highlight it here. Remember we were talking about the network of veins associated around the spinal cord, and I said there was an external and an internal network, and that's how metastasis can make its way to the bone. Here's the example that you see right here. You see the metastatic, the tumor sitting in here between the vertebral bodies of L4 and L5. When you're talking about cancer being so painful, it's the bone pain that's usually most of the time the culprit. And this is a prime example of where you find that bone pain. Now the muscles of the back, this is what we're going to do today in lab, and we're going to blast through these things. It won't take very long to do. And by the way, just to let you know, I will stay as long as possible, as long as you have questions. If you don't have questions, I'm going to leave in the afternoon, okay? I usually check with you to make sure, see if you have any more questions. There are a couple of times when I have board meetings and things going on at night. I had one last night, I got another board meeting tonight, I've got another meeting tomorrow night, I have another meeting next Wednesday. Otherwise, I don't think I have anything else going on the month of January. Hopefully I don't. So, I'm not trying to bug out on you, but if you have questions, make sure you hit me, okay?
I know we're not allowed to take any pictures in the lab, but could we take a picture of the dissector?
Absolutely. Take a picture of the dissector. Yeah, I would encourage you to do that. Yeah. I think I said that earlier today.
Yeah,
Did I say that earlier today?
I've posted that.
Yeah, I was
already.
just,
You're smoking something. Okay, so there are three layers of the muscle in the back. There's a superficial muscle layer that you found yesterday, essentially. These muscles act on the extremities, particularly the upper extremity. The intermediate layer are muscles for respiration. The deep layer is called the true back muscles. They act on the vertebral column. So if we look at them individually, in groups, this is the superficial layer here. We found the trapezius yesterday. We found the inferior border of the trapezius, The trapezius runs from the spinous processes of the thoracic all the way up through the cervical vertebra and actually onto the back of the base of the skull. It flares out and attaches along the spine of the scapula here. The trapezius acts on the scapula. The humerus is attached to the scapula by several different muscles. So if you act on the scapula, you're obviously going to act on the humerus, the upper extremity. The other muscle, on the back side of the trapezius, you see here, is the spinal accessory nerve, cranial nerve 11, spinal accessory. What the trapezius does, one of the most movements of the trapezius, is it causes you to shrug your shoulders. Okay, shrug your shoulders. Ease it up. And the physical exam, that's what you do. You put your hands on the patient's shoulders like this, shrug your shoulders. Okay? And you're testing for symmetry and strength. That's all you're doing. Now you just said cranial nerve 11 is intact. When you are asked to find it today, all you do is you cut the trapezius off of the spinous processes like you see here and flip it up, and you're going to find it right there on the back side of the trapezius. Now obviously it's bigger up here at the top because by the time you get down here, you're already innervated most everything. We'll find the trapezius, the spinal accessory tomorrow in the neck, and you'll see where it goes onto it enters the trapezius from the top part right here. It's an easy nerve to find. The latissimus dorsi arises from the thoracolumbar fascia here and comes up and under forms part of the posterior axillary fold. It attaches to the underside of the humerus here. It adducts the humerus, and because it comes from this way, if I pull it, I will internally rotate my forearm, my brachium here. Okay? And it also extends it. So it has those three actions. Adduction, internal rotation, and extension of the shoulder. It's innervated by the thoracodorsal nerve. The artery that supplies it's also called the thoracodorsal. We'll dissect those later on. The other muscles that act on the upper extremity, if you remove the trapezius, underneath there you'll find the rhomboid major and the rhomboid minor and the levator scapulae. Those three muscles are right in a row. They run from the spinous processes to the vertebral border or the medial border of the scapula. And what their role is, the rhomboids are going to help you do that. They're going to take the scapula and pull them backwards towards the midline. The levator scapulae will take and raise the scapula towards that superior angle of the scapula up. Okay? The nerves to those and the arteries to those, the nerve to the rhomboid is called the nerve to the rhomboid, and nerve to the levator scapulae. Highly technical. The artery here is, we're going to call it the dorsal scapular artery. The rhomboids and the levator scapulae. Now, there's another name for that dorsal scapular artery. It depends on where it branches off in the neck here. Sometimes it's called the deep transverse cervical artery. I'll explain it tomorrow, but suffice it to say today that if the artery to this area comes off the subclavian by itself, it's called the dorsal scapula. But if it comes off as a trunk and divides into a deep and superficial branch, that's when it's called deep and superficial transverse cervical. The deep branch goes to the rhomboids. The superficial branch supplies the trapezius. Alrighty. There is a triangle of auscultation in the back that's right there. It's formed between the the rhomboids, the trapezius, and the latissimus. And it's called this because there's no muscle over there. If you're going to listen to the chest, auscultation is to listen. That's the best place to do it because there's less interference from having to hear sounds through a muscle mass. There's another triangle down here. It's called the lumbar triangle. It's between the latissimus, the iliac crest, and the external abdominal oblique. There's a little triangle here not protected by muscles, and on rare occasion, you can herniate intraperitoneal fat through that lumbar triangle. I had this woman come in one time, she's kind of a big woman, and she had this bulge down here. And I'm thinking, good gosh, what is that? I thought it was a lipoma. You know, it was big, though, it was big. I thought it was a huge lipoma. And she was a big woman anyway, so it was kind of hard to tell. But it was obviously a palpable big mass there that, well, I'm not going to cut that thing out without knowing what it is. So I sent her for a CT. Actually, what it was her, the kidneys have a lot of fat around them. It was actually her renal fat that had herniated out through that lumbar triangle. It was the weirdest thing I'd ever seen on an image. So that's the only time I've ever seen a hernia through the lumbar triangle, although they describe it in the literature. The intermediate layer of the muscles of the back, just two of them. They're little sheet-like muscles. They're mostly tendinous. There's one here, it's called the posterior serratus superior. The fibers run that way. At the bottom of the chest, there's the serratus posterior inferior. And I pointed out yesterday on one of the cadavers, I said, don't cut this little flat sheet muscle. Who was that I did that yesterday? You got, what number are you? What cadaver? Two? Group two?
Yeah.
Take a look at it before they start hacking it all up today. But they have, yours, you got a very good posterior serratus inferior yesterday. These things are innervated by the nerve to the posterior serratus inferior and superior, so meaning that I don't care that you know what the name of the nerve that innervates it is. As a matter of fact, when I talk about origin and insertions, people get hung up on how much of that I need to know, because this will say it arises from the spinous processes of T9 through T12 and inserts into the ribs 6, 7, and 8 or something like that. I don't care that you know that. As long as you know the specific origin and insertions, I don't care that you know that. As long as you know that it comes from over here by the vertebra and it inserts over here on the ribs, so it must be a muscle of respiration. That's close enough to me. Okay? So we're not that particular. It's more important that you know the function and the innervation and the blood supply. Okay. The next layer of the muscles will be the deep muscles. A few of them we're going to dissect, some of them we're not. This group right here, the transversospinalis group, they're made up of 3 teeny little muscles, and they run from one vertebra to the next. And they're mostly present down here in the lumbar region, except for semispinalis. But these things, these small muscles, you don't need to find down here, okay? What you need to find down here are the 3 muscles that make up the erector spinae. That would be the spinalis muscle, which runs from spinous process to spinous process. The longissimus, that runs from the iliac crest and sacrum up into the upper ribs and vertebra, mostly the transverse processes. And finally, most laterally, you have the iliocostalis. The iliocostalis runs up and attaches to the ribs proper. Now, if you look on this thing right here, there's an iliocostalis lumborum, there's an iliocostalis thoracis, there's an iliocostalis cervicis. I don't care that you know that. Okay, as long as you just know that, look, this great big ass muscle down here is attaching to a rib, it must be iliocostalis. okay? All right, we clear on that?
That was my question.
Okay, good deal. If we go up here to the cervical region, you're gonna see a flat muscle called the splenius. Splenius means bandage, so it comes from either side and wraps around and attaches to the skull. And inferiorly, the splenius cervicis, that's called the splenius capitis. The splenius cervicis wraps around and actually comes back up and attaches to the cervical vertebra. It's just the most inferior margin of splenius. I don't care that you separate those two or identify them as separate muscles. Just know that it's splenius. Underneath splenius, you'll see this muscle here is semispinalis capitis right here. Semispinalis capitis is a member of the transverso spinalis group, but it's so large up here, that's why it's easy to find. Okay? So here's the deal. The deep muscles of the back, are being true back muscles, are innervated segmentally by the dorsal primary rami. They're within a couple of inches of the spinous processes is dorsal primary rami. All of them. You don't need to identify one or the other. Okay? The levator scapulae, the rhomboids, the trapezius, the latissimus, they are all innervated by either ventral primary rami, or in the case of the trapezius, a cranial nerve. And of course, these muscles acting together bilaterally. Unilaterally means one side. Bilaterally means two sides. Ipsilateral means same side. Contralateral means the other side. Right? You know those terms? So if they act together, they're going to extend the vertebra, depending on what levels are acting on it. If one side contracts in the other, it's going to rotate the vertebra like that, okay? These small transverso spinalis muscles are used for rotation at the segmental level versus at the unit level for the others. Here's a little thing that you're not going to have to dissect, but I wanted to show you because you're probably going to be affected by it sometime this year. So here's, we've removed semispinalis capitis over here on this side, and underneath that are going to be four little muscles that run from the C1 and C2, the posterior aspects, to the base of the skull, or from C2 to C1. They're called, together, it's called the suboccipital triangle. You can see it better in this image here. The suboccipital triangle. You don't have to dissect these little muscles, but the reason I want to point them out to you is some of that tiredness that you're going to be getting this year is not necessarily the large muscle groups like splenius and semispinalis and trapezius, but these little guys like this, okay? The other thing about these is they serve as a landmark. One of the things in your dissector, when you open it up and get up to this region, they're going to tell you to find this nerve right here, which is the greater occipital nerve. If I go back to this slide, you see it poking out through the semispinalis capitis. The greater occipital nerve, it's not labeled on this thing, the greater occipital nerve is C2. What does C2 do? Right, it provides sensation to the back of the skull. Right? So where's C1? I said C1, I said yesterday C1 was all motor. It didn't have a dorsal root. Where's C1? C1 is the nerve to the suboccipital triangle. That's C1, that's C2, that's C3. That's C1, that's C2, then that would be C3, C4, and so on. So, if C1 doesn't have a dermatome, Does it have a dorsal root ganglion? No. Does it have a dorsal horn? I mean, does it have a, not dorsal horn, does it have a dorsal root? No. It's all motor. So if I ask you what are the functional components in C1, you would say somatic efferent. It's motor to the suboccipital triangle. Within the muscles of the suboccipital triangle, there are blood vessels, right? So it's got to have visceral efferent. Wherever there's visceral efferent, there's a visceral efferent. There are three components in C1. In C2, there's no muscle that it innervates. It's only sensory to the back of the skull. So it has a dorsal root ganglion, it has a dorsal root. It has somatic afferents to the back of the skull. Does it have visceral efferents and visceral afferents? Yeah, you have blood vessels in the scalp. It just doesn't have somatic efferents. All the rest of the nerves on the way down have all four components. Those are the two exceptions, and I told you I'd tell you what they are. Now, you don't have to find the suboccipital triangle. You don't have to find that nerve, the greater occipital nerve, because by the time it goes through the semispinalis capitis, it's now just going to be a cutaneous nerve. It's going to be little. If you really want to find this nerve, remove the semispinalis and find it coming through. C1 comes out the triangle. C2 comes out inferior to the triangle right there. It comes out through the semispinalis to supply the skin of the back of the skull. Okay? I think that's it. All right, see you over there.
That last thing I just did. It was like, today.
That's why I didn't remember. Good thing about the C1. We both have common roots.
Same, nothing different. Except that last part, we gotta go back and do the parent stuff, but the rest of it, yeah. Well, I agree.